that must be met to say that this particular person is having a sexual dysfunction. And so the criteria for the diagnosis of sexual dysfunction include: one, an inability to participate in a preferred sexual relationship. This is the type of relationship that I want to engage in. I want to engage in an heterosexual relationship, but I am unable to enjoy and engage in this heterosexual relationship. That's first of all, one. Then the presence of the individual dysfunction must occur in almost all occasions. So in almost all situations, there must be that particular dysfunction you are talking about. Hello?
Yes,
Hello?
please go on.
Okay. Then the minimum duration for us to be able to make that diagnosis is that it has to be at least 6 months duration. And then that particular dysfunction must cause distress or interpersonal difficulties to the individual. It must be affecting the person going to work, the person's relationship with family, the person's relationship with the partner, and a host of others. Then this particular sexual dysfunction must not be from a physical disorder or drug treatment or another mental or behavioral disorder. So for example, another mental or behavioral disorder, somebody who is depressed and severely depressed, we expect that the person would have a low libido. And so in the context of a criteria that meets the diagnosis for depression, we cannot say that the person is having a sexual disorder. That is the understanding in this particular place. In the context of someone who is taking a particular drug, a drug that is causing the person to have a low libido, or a drug that is causing the person to unable to achieve orgasm, in such an instance, we cannot say that the person is having a sexual disorder. Then finally, for a physical disorder, somebody, for instance, who is having a stroke, and the stroke is preventing the person from engaging fully and enjoying in the preferred sexual relationship, such a person, we cannot say that the person is having a sexual disorder. So we need to rule out all of these things in order for us to be able to make a diagnosis of somebody who has a sexual dysfunction or a sexual disorder. Now, the common triggers for sexual dysfunctions, I would want us to talk about these things and highlight these things. In fact, 60 to 70%, Dr. Sehonia, can you see me moving in my video?
No, the video has frozen, but the audio is perfect.
Yes, I don't know why the video has frozen, but we'll just continue. Since you can hear me, that's fine. So 60 to 70% of sexual dysfunctions are triggered or caused by psychological factors, especially during in a relationship. One, life stresses. I would want us to talk really more about these things because these are the common things that people come to the clinic with. And for all they know, it is just because that the person is stressed in life. So when we talk about the life stresses, we are talking about chronic stresses from work. We are talking about all the time you are stuck in traffic for a very long time. You are so stressed up that when you get to the house, your partner even wants to touch you, but you are not interested. And if that happens all the time in every single situation, it becomes obviously very difficult for you to enjoy sex. If a woman who is at home all the time and the children are pestering this woman, the woman shouts all the time, does a lot of household chores, and at night,
Dr. Azu is having some network issues. He will be joining us back briefly. Let's hold on. He's going to join back briefly. Yeah, Dr. Azu is trying to join us back briefly. He just got off because of some network issues. He's joining us back briefly. All right, so Dr. Azu was taking us to the criteria that has to be met before somebody is diagnosed with a sexual disorder or sexual dysfunction. It's not just a one-off. It has to be something that has been going on for quite some time, at least 6 months, not just a one-time encounter. That's what he was telling us, some of the causes, what contributes to you having that diagnosis. He's just had a network issues, called, he's getting back on shortly. He's joining us back shortly. So let's just hold on as he joins us back. All right. Sometimes technology, these things happen. Sometimes technology, these things happen. He's having some a little challenge with the network. He's joining us. He's joining us briefly. He has a lot to share with us today. So let's just hold on for the next 10 seconds. He's joining us. Gotten him. He's joining us shortly. All right, Dr. Azu, welcome back. Welcome back. Welcome back. Thank you very much. All right, so if you can just briefly go over the criteria for the diagnosis, start from there and just quickly take us through. Thank you very much, Doc.
Okay. Thank you. Sorry for this mishap.
Doc, I advise you stop the video. Let's use audio only. All right, thank you. Let's go.
Okay, okay. All right, can you see my screen now?
Yes. Yeah.
Okay, it's on slideshow. Can you see?
Yes.
Okay, all right. So sorry about that. So we're talking about the criteria, and I think this was where, so for us to make a diagnosis of somebody who has a particular sexual dysfunction, first of all, the person must have difficulty in engaging in that particular person's preferred sexual relationship. If the person wants to be in an heterosexual relationship, this is how heterosexual people do have sexual intercourse, and the person is unable to achieve that, then it becomes a problem. The person is in an homosexual relationship. This is how homosexuals do have their relationship. The person is unable to do that, then it becomes a problem. Then that particular dysfunction the person is having must be occurring almost all occasions, and it must last for at least 6 months. So a one-off incident cannot be used as a diagnosis of somebody having a sexual dysfunction. Then it must also cause significant distress or interpersonal difficulties to that person. And it must not be as a result of a physical disorder. For example, someone who is having a stroke and cannot have sex, we cannot make a diagnosis of sexual dysfunction or a sexual disorder, because what the problem is the stroke and not the sexual dysfunction. Somebody who is using a particular drug that has caused him to have a particular sexual problem, we cannot make a diagnosis of a sexual dysfunction disorder. Or in the context of what? Depression. Somebody who is depressed and has low libido, such an in person, we cannot say that the person is having a sexual disorder. Then we were talking here, I don't know if here I spoke about this. Did you hear this side?
Yeah, you were talking about a woman who is at home all day with the kids worrying her.
Yes, very good. Excellent. Yes, so this one, I was talking about the anxiety. So the life stresses. So a woman who is usually at home and taking care of the children is so stressed up with daily hustle and life activities. Such a person whose husband would wake the person up at about 5 a.m. and want to have sex with the person, it will be difficult for the woman to enjoy sex. It may even be difficult for the woman to even have the desire for the vagina to lubricate. And such an instance, it will be very difficult. And that alone can even be the trigger for the sexual dysfunction. Then we're talking about anxiety as well. The anxiety includes having an anxiety disorder and having a performance anxiety. Somebody who has a sexual performance anxiety is worried, how am I going to do this? Will I be able to satisfy this woman? Oh, look at this woman. This woman looks like somebody I have to have sex with for 1 hour. Thinking about all of these things. Then you go back and under 1 minute, you are gone. That's a sexual performance anxiety. In such an instance, it is likely to occur in the next sexual intercourse because it has happened already and you are well aware of it and thinking about it. And when this continues to happen, it's more like a vicious cycle and it becomes very difficult. Then low self-esteem. You are who you think you are. You understand? And so if you have a low self-esteem and a low confidence in yourself and think that you have a small penis, it may be difficult for you to satisfy the woman. And if during the sexual intercourse, all you are thinking about is the fact that my penis is small and I'll be unable to satisfy this woman, in fact, it will happen that you will be unable to satisfy the woman because that is all you are thinking about. And so you are not focusing on other areas. So low esteem is one of the commonest triggers of sexual dysfunction. Penis or size does not matter. What matters is technique and skill. Technique and skill is what matters, and not penis size. In other instances, some people think that, oh, my partner doesn't like watching or looking at my breast. I have a small boobs. I have stretch marks, and so I want the lights off. I have this particular disfigure about myself. Such low esteem, thinking about such things would not make you enjoy the sex fully. Then excessive self-monitoring of arousal. That is like those who have the various small deformities. Either you have small boobs, small stretch marks, and all of those things, and you are monitoring yourself and assessing yourself. Instead of enjoying the act, you are thinking and monitoring what you are doing. You are supposed to touch the woman in this particular way, yet you are touching the woman in a different way. If you continue to think about that, then frequently you would have a difficulty in enjoying sex. Feelings of guilt about sex. Our very religious men and women who are so guilty that you are going to have a premarital sexual affair. The mere fact that you have that guilt, it would be difficult for you to enjoy sex fully. If sex is going to be, in your belief, only in the context of marriage, then wait until it is in the context of marriage for you to have it. And please take this from me, my dear listeners, that engaging in sex early or engaging in premarital sex is not a visa to being good in bed when you marry. I hope I am clear. It is not a prerequisite for somebody to be very good in bed if you have had sex in your 80s, if you have had sex in your 20s. No, you can get married, learn about sex at the right channels, and be best at sex. And I would want to state this emphatically, that as a matter of fact, the father of sexology married at 35 years and was a virgin until the person married and was able to come up with a lot of sexual theories that you and I are learning today. Another trigger of a sexual dysfunction is a fear of getting pregnant and fear of STDs. Then a lack of knowledge about sexuality and a normal sexual response. If you are having sex with your partner and your partner is mourning and you do not know that the mourning is a part of the sex and is a part of what would make the woman to enjoy the sex, or if you are the woman and you are mourning and you think that I am mourning so loud and do not allow your natural self to mourn, you may end up not enjoying the sex as you should be. Then a previous negative sexual experience is also likely to cause somebody not to enjoy sex. Somebody who has been raped before, somebody who has had a sexual abuse, and all these previous sexual encounters with somebody that you did not enjoy. Another very common trigger is environmental. So where you are having the sex. If you're having the sex in a park where you are not supposed, it's illegal, you are likely to come early. If you are having a sex and you fear that somebody is going to see you, you would want to probably do a quickie. If in all instances this happens, such a person, we will not classify such a person as having a sexual dysfunction. But if all the time, anytime you're having the sex, you have children around and you do not want to have the sex, you feel physically discomforted because you are having the sex in a car and you are not doing it very well, these are very common triggers of sexual dysfunctions. You are having the sex in or on a bed that is not comfortable to the person. The woman lies and is having back pain, very common. Then you also have the physical causes like medication side effects, which I mentioned, pain or discomfort dealing with illness, feeling very tired, and a recent childbirth. All these are very common triggers of sexual dysfunctions. Then we also have the factors that are related to the partner. One, sexual attractiveness. Obviously, you are not going to enjoy sex, or you are likely to have a disordered sexual intercourse if you are not physically attracted to the person. For someone who is not attracted to men, and is a man, obviously the person cannot have sex with the man. Then evidence of disinterest. If in the process of foreplay, you notice that your partner is not interested in what you are doing, it can be a prerequisite for a sexual dysfunction. Then constant criticism. This is very, very important. You're having sex. In the process of sex, sex is had with all your senses. And so if you're having sex and you continuously criticize your woman or your partner, why are you doing this way? Why are you doing that way? And all of these things do not tend to calm the person down. And if the person is not calm, the person would be unable to enjoy the sex. If you are complaining that your partner is doing certain things wrongly, then it becomes very difficult for you to enjoy the sex fully. And this is tied to the being inconsiderate to your partner. Your partner is very tired, exhausted physically, you can see it, but yet you still want to have sex with this particular person. And then inability to cope with certain difficulties, especially sexual. You have a man who probably has a very big dick, and you are able to meet up with this particular person. It will be very difficult for you to enjoy it. Then, very importantly, is the being sexually inexperienced or using poor techniques. And the other last one is the fact that your partner prefers a particular sexual activity, but you want something else. If your partner wants doggy, but you do not want doggy, it becomes a challenge. And so one of the main things that we would usually want to identify are what is the interest of your partner and what is the interest of the other partner. And we find a way to balance and meet these two things. Now, to the various sexual disorders, we'll take them one after the other. So at the desire phase, we have what we call sexual aversion disorder. And individuals who have a sexual aversion disorder, they have very strong negative feelings. They fear and have very anxious feelings when they are about to have a sexual interaction. And therefore, this makes it difficult for them to sufficiently enjoy sex. Then what they will do is that they then actively want to avoid the sexual process. We have individuals who are like this. And sometimes this may stem from some of the psychological triggers I mentioned earlier. For example, someone who has had a very rough childhood where the person was raped all the time. Such a person may have a phobia for sex. Such a person is likely to have a disorder, sexual aversion disorder, where the person has a strong dislike for sex in general. Number two is a lack of sexual enjoyment. Such people, they want to have the sex, they are ready to have the sex, they do everything that they need to do. During the desire and excitement phase, the person's vagina is lubricated or the person's penis is lubricated, is erect, but yet the person is doing it and is not enjoying it. That is lack of sexual enjoyment. And this can also occur in some people. So for such conditions, we would usually want to find out what the triggers are and find out the various psychosocial factors that are causing this particular reason. And then once we get these things, if you get an experienced therapist, we'll take you through the therapy in order for you to get out of it. Because if you are able to remove your mind and isolate the incidents, allow the fact that the incidents has happened in the past and is in the past, and put yourself in the present, then such people with sexual aversion disorder and lack of sexual enjoyment may begin to enjoy sex, and they may begin to realize the full potential and benefits of sex. Then we also have hyperactive sexual desire disorder. This is like the lack of sexual enjoyment, but in these people, they have the desire, but the desire is not sufficient enough to make them want to have sex. So they have decreased pleasure when they are thinking about wanting to have sex. We have, obviously, like I showed you in the diagram earlier, where you have the desire phase, excitement, and then the plateau. People who, once you have the desire, you are in the excitement phase, you start to develop feelings, you start to develop a sense of tension and anxiety, a sense of likingness for the sex. These people, they do not have that anticipation. And it can occur in three types, in three ways. We have the primary and the secondary and the situational. In the primary, they have never had a sexual desire. In the secondary, they have had sexual desires in the past, but now for some reason, they have lost it and they are no more getting it anymore. In the situational instance, it is only in specific settings or in particular partners that they have this hypoactive sexual desire. Anytime you're about to have sex in a particular room, you do not anticipate, you do not have that desire. But if you move from that particular room, then you would have the desire. And so for a diagnosis, then the loss of sexual desire ought to be secondary to other sexual disorder. It must not be as a result of another sexual disorder, like dyspareunia and then erectile failure. For this management, we would want to identify what the underlying cause is and then refer to a specialist for what we call a sensate focus technique to be done. When I talk about sensate focus technique is a technique that teaches you to enjoy your partner, to enjoy foreplay. And in a sensate focus technique, we allow the two people, the partners, to touch each other. You are touching each other from head to toe and examining and watching your partner, looking at your partner's erogenous zones. When I talk about erogenous zones, I am talking about the parts of your partner's body that excite the person. You get excited when you touch your partner erogenous zone. But if the person gets excited, the technique is that we will not allow you to have sex. So you will not penetrate, although the person is enjoying. So this would help you to identify certain areas, and it will help the person to build up that desire and that anticipation for sex. Then finally, you can then go ahead and have the sex. And in some instances, we would want the technique to end in masturbation. Then we have another sexual disorder, which is excessive sexual desire. Please take note of this. Excessive sexual desire occurs when one partner makes unusual demands as a result of an increased sexual drive underlying. And this person may have sexual disinhibitions where they cannot control their libido. And if they cannot control their libido, they will have sex in places that they should not have the sex, one. They would have sex at times that they should not have the sex. They would have sex with individuals that they should not have the sex with. Excessive sexual desire in women is called nymphomania. In men, it is called satyriasis. If this is in the context of a partner, of a couple, and I'm with my wife and I, we do have sex. For example, this is an example I am giving. We have sex 3 times a day. My partner is satisfied. I am satisfied. We will not make such a diagnosis as excessive sexual desire. We will not say such a person has satyriasis. Satyriasis only occurs if you are unable to meet the demand of your partner. That is when the excessive sexual desire comes in. And there is no straitjacket that fits all. It depends on the partner, on the partners involved. And these usually occur very late in the teenage and sometimes in the early adulthood, and sometimes they may be secondary to mania. People who are manic are very hypersexual. And sometimes in some form of dementias, especially the frontotemporal dementias, they may experience certain things. Some people who also have learning disability may experience this excessive sexual desire, and also sometimes secondary to a traumatic brain injury or as a side effect of some drugs. And so if you have any of these things, that is why you need to see a specialist where proper history will be done, identification will be done, and the underlying cause will be treated. Then in the excitement phase, we have what we call the failure of genital response, where the person is being stimulated, person has a desire, but yet the genital changes that you expect in the excitement phase are not occurring. For example, you are touching the partner as much as you can touch, you are kissing her as much as you can kiss, you are fondling her breast as much as you can. In some instances, you are giving, you are fingering her, but yet the vagina is still dry and there's lack of lubrication. This is, in this condition, we call it failure of genital response. This most of the time is due to psychological factors or physical problems. All right. So then in the management of these cases, we will want to give them lubricating gels, example, Vigorol. We may do estrogen replacement therapy and then reduce factors that inhibit arousal. Next is orgasmic dysfunction. So in orgasmic dysfunction, it is very common complaint in women, and the experience of orgasm is either delayed or it doesn't even occur at all. Despite the fact that the person is aroused fully and excited fully, individuals may never even have an orgasm. And it is also classified into three main groups. We have the primary, we have the secondary, and the situational. In the primary, they have never achieved an orgasm. In the secondary, they have achieved an orgasm before, but now they are no more experiencing. And in situational, it is only in certain situations that they can get an orgasm. In certain situations, they get, in other situations, they do not get. All right. I've been alerted that my time is almost up. I'm almost done, so we'll finish very quickly. So in the management of this, we would want to, first of all, solve any secondary problem or psychological issue. Then we would also help the people with self-help programs, such as directed masturbation, sensory focused technique for the couples, and then Kegel's exercise, pelvic floor exercises, and then the use of sexual fantasies to help the person to also to achieve an orgasm. And very complex cases are usually referred to sexual therapists. Another condition is the non-organic vaginismus. And in this particular instance, you have spasms of the pelvic floor muscles resulting in painful or impossible penetration due to blockage of the vaginal opening. And this is not as a result of a particular physical condition. And the vaginismus would usually occur and lead to pain during sexual intercourse. And so anytime the person is coming to have sex, the person is thinking about the pain that he has previously had, therefore causing more pain. This particular condition is vaginismus. In the management of this, we would want to physically examine the person to ensure that the person is not having any obstruction in the vagina. Then would also educate the person and dispel certain myths and misunderstanding the person is having about sex. Then we'll let the person engage in relaxation techniques, Kegels exercises, and then we'll use graded trainers. Graded trainers are libido, are dildos in different sizes that we will let the person use gradually in order to open the person up, and then reassurance from the partner that all is going to be well. Then we also have non-organic dyspareunia. Dyspareunia just simply means pain during sexual intercourse. And the pain during sexual intercourse in non-organic is occurring without any physical disease. So the person is not having an infection, the person is not having white, the person is not having a tumor, and yet anytime the person is having sex, the person has pain. In this instance, it is not caused by vaginismus. You would have, there's no spasm, there's no narrowing of the place, but the person just experiences pain. And so the management, we want to exclude organic causes, teach them relaxation techniques, and then educate them on arousal before sex. Then we also have another condition called the pelvic congestion syndrome. And it is the experience of deep pain after sexual intercourse. Take note, this particular pain is slightly different from dyspareunia, which is more superficial. And it occurs as a result of a lot of blood that has been accumulated during the stage of arousal and excitement, and yet the person does not achieve an orgasm. This is common in women, and it is what we call blue balls in a woman. It is the equivalent of blue balls in a woman. And the treatment of this is to ensure that the person orgasms. That is all. We let the person come. Either the person would have the sex, or the person will masturbate using a vibrator, and the pain will go away. Now, I left this particular slide to the last portion, erectile dysfunction, and I would want to briefly define what an erectile dysfunction is. So now, erectile dysfunction is the consistent inability, I repeat, consistent inability to achieve and or maintain an erection adequate for satisfactory sexual intercourse. Although you may see that the definition is very simple, the condition is as complex as the earth. So this is the anatomy of the penis. And I just want to briefly explain to you what happens during erection. In simple terms, and because time is not on our side, when the nerves are stimulated, either via touch, either via seeing, or either via just your mere thought of wanting to have sex, there is a substance we call nitric oxide that is produced. This nitric oxide will go ahead to stimulate what we call GMP. The GTP is converted to cGMP, which will cause these, what we call the corpus cavernosum, which is like a sponge. They become dilated and blood flows into this particular area. When the blood flows into that particular area, it compresses on these are the veins. The veins are for the outward flow of blood. And when there is the outward flow of blood, you have detumescence. So when this becomes very, when it is full with blood, it compresses on this and prevents outward flow of blood. And so the person maintains the erection. And this is what happens. Once you achieve orgasm, there is detumescence, and then the blood flows back through the veins and outward. So in a normal male, you have an intact libido, you have blood flowing, causing it to erect, which is tumescence. You have the sexual intercourse, you ejaculate, and then you detumescence. And the part of your body that is responsible for you getting an erection are the parasympathetic nerves. The parasympathetic nerves act when you are at rest. And so no man, I repeat, no man can get a good erection if the person is not in a state of rest, if the person is not calm. And so if you do not touch the man to make the man calm and at rest, it will be difficult for the person to get an erection. And ejaculation is caused by the sympathetic nerves. Sympathetic is what is usually produced when you see a lion and either you want to attack or you want to run away from the lion. And the detumescence is also influenced by the sympathetic. And so you will realize that in the process of having a sexual intercourse, I'll give an example. You're having a sexual intercourse, your child is in the room, your child is in the hall, but all of a sudden tries to come into the bedroom. You get a sympathetic overdrive, and you would come quickly just because of the overdrive in the sympathetic nerve system. And so these were the sinusoids I was talking about. So these ones get engorged like a cushion that has been inflated with blood. And these are the veins So if you have, this is in a flaccid penis. And so if you have blood coming in to fill this particular side, it compresses on the veins and prevents the outward flow of the blood. And so the person is able to maintain an erect penis. What are the types of erectile dysfunction? You can have primary erectile dysfunction. In primary erectile dysfunction, the individual or the man gets an erection prior to sex, prior to the sex itself, starts having the sex, and the erection goes away. That's in secondary. In secondary, you have the erection prior to the sex. Then once you start having the sex, the erection disappears. In primary, you are unable to even get the erection to start the sexual process. And no matter how much they touch you, no erection. Kofi refuses to get up. In situational, in certain situations, in a particular woman, you may get an erection. In another woman, you may not get an erection. In a particular environment, you may get an erection. In another environment, you do not get an erection. Erectile dysfunction is more common in older men than younger women, than younger men. Whereas premature ejaculation, please take note of this, premature ejaculation is more common in young men than in older men. This is what the statistics shows us. And so what are the causes of erectile dysfunction? These ones are also very common, and they're also similar to the causes of premature ejaculation. So you can have psychogenic, which were the ones that I mentioned earlier. You can have vascular, like hypertension and atherosclerosis. You can have systemic diseases like diabetes. You can have neurogenic causes, spinal nerve problems, when you have trauma, and then you have the impacting any of the spinal nerves, either the sympathetic nerves or the parasympathetic nerves, you may have a problem. Then you may also have hormonal causes of Dr. Sedon here, please alert me when my time is almost up so I don't talk too much. Then you may also have, all right, you may also have hormonal problems where the person is having either low testosterone or higher estrogen, whichever of them. Then you can also have drugs. There are certain antidepressant drugs, certain antihypertensive drugs, and certain drugs that are used for the treatment of kidney issues that causes erectile issues. And this is the treatment algorithm. Most of the time, we would want to consider general measures. So like lifestyle changes, diet, exercising, and or what medication are you on? Do you have any underlying condition? Then when that fails, we move on to sexual therapy, sex therapy. And then if the sex therapy, which usually involves behavioral changes, teaching the person the techniques of having proper sexual intercourse, if that fails, then we'll move on to drug therapy. And there are certain drugs that we can use in the treatment of erectile dysfunction. The common ones, which a lot of people know, are Viagra, but we also have other natural remedies that we use. Then we can then go on to the vacuum devices and then the surgical implants. So I would want listeners to take note of this, very, very important. If a young man is having an erectile dysfunction and does not go to the proper channel, or does not see the proper person responsible for that, most of the time, what happens is that you are likely to go to the pharmacy and say, I'm unable to get an erection. You are likely to get the drug peddler by the roadside that you're unable to get an erection. Then you jump to the third stage of the treatment. And when you jump to this particular third stage of the third line of the treatment and bypass all of these things, you are actually worsening your situation. And in your 40s and in your 50s, you may even be unable to get an erection at all. And so if management would usually involve a full assessment of the individual, because we want to assess the person, take a history, a proper history to find out any of these psychological factors, to take a proper history on if the person is having sex country. All right. If the person is having sex in the right manner and the person is involved in the right technique for sex, this is very important. Then we'll use a particular test that we a questionnaire, which we call the International Index of Erectile Dysfunction. It's a 5-scale questionnaire in a total of 25 marks. Based on where you are, we'll classify your erectile dysfunction as either severe, mild, moderate. Then we would examine the penis to find out if you have any organic cause. There are also some things that we call penile plaques that are usually inside people. Then we'll do certain investigations. And the investigations as to rule out underlying causes like testosterone and hormonal prolactin, and then those other things. Then there is also another a test of erection in REM sleep. And we'll use what they call this the snap gauge and a strain gauge. The snap gauge, for instance, you tie a tape. You know, any man who is sleeping, there are 2 stages of sleep, REM and non-REM. In REM sleep, men usually have spontaneous erections. These erections, in a normal person, you can have 5 to 6 erections in the entire night. So when you are erect, it is full erection, proper erection. So the snap gauge is used prior to you sleeping in a flaccid penis. Then you tie it, it is tied around it. When you have an erection, then the tape will cut. You wake up and you come and tell your therapist that this was what happened. Then we are able to know that, yes, you get erections during REM sleep. And that would help us to rule out neurogenic causes. You understand what I'm trying to say? That would help us to rule out certain causes of your erectile problem. Then we talk about premature ejaculation. Very important to a lot of people. A lot of people want to hear. It is the perception of an inability to control your ejaculation. And it occurs either sooner than expected. Either immediately you are trying to penetrate or shortly after penetration. Then to make a diagnosis of premature ejaculation, the other criteria for which I stated earlier about diagnosing sexual dysfunctions must also be present. Must be the duration of 6 months. It must not be a result of an organic condition. Then we rule out other tests before. We have what we call a lifelong premature ejaculation, which is very common, like I said earlier, among men less than 40 years. And it occurs nearly all the time with any woman at all. And most of the time, it is under 1 minute. And so a 1 minute man, all the time, 1 minute, all the time, 1 minute. You have to, maybe you may have a premature ejaculation. And for the management of this, we go through the same process like we did in erectile dysfunction. We'll take a proper history, want to identify any underlying cause and treat the underlying cause. Then we have the behavioral therapies that we will show you, which is the start and stop technique, and then the squeeze technique. And then we also have certain ways in which we teach you to masturbate. And then after masturbating, then you would have the sexual intercourse. Then a proper way and channel of having sex. Maybe the person is not having sex right. And so we'll teach you how to have the sex right. And like I would always say, the act of sex is an art, and that art needs to be learned. And if you do not understand this art, you may not fully enjoy sex, and you may be ejaculating in less than 1 minute and think that it is the norm. No, it is not the norm. Then once the behavioral therapies fail, then we have drugs that we would give. Most of these drugs, some of these drugs we give are SSRIs, very short-acting SSRIs. And to other doctors who are listening to us, we have drugs like dapagliflozin that we can give. It's a very, very short-acting SSRI. Then we also have topical creams that we would give, usually involving lidocaine. That include lidocaine. That would help delay delay your ejaculation. So very important. And I would want to end with this particular quote that, ladies and gentlemen, man has survived earthquakes. We have experienced several horrors of illness and all of the tortures of the soul. But the most tormenting tragedy of all time is and will be the tragedy of the bedroom, the tragedy of having improper sex, the tragedy of having zero knowledge of mathematics. And so let us learn right and always hear from the experts on Dr. Sedohia's channel. Thank you very much. I would end here and pause for questions. Dr. Sedohia, over to you.
Thank you very much, Dr. Azu, for such a thorough presentation on the various sexual disorders. Can I push you a little to just touch briefly on the paraphilias?
Yes.
Yes, so if you can touch briefly on the paraphilias. Yes,
so we can talk about the paraphilias. When we talk about somebody who is having a paraphilic disorder, the person is having an interest in an unnatural, this is a definition. The interest is in an unnatural body or an unnatural being lasting for a period of 6 months. We all know what the natural is. The natural is the desire and sexual fantasy or sexual intercourse via penis and vagina. This is what the natural is. And so somebody who has sexual desires and fantasies or urges to any other thing that is unnatural of this particular nature is defined as having a paraphilic disorder. 2, the desire must last for a period of at least 6 months, according to DSM. ICD doesn't put any duration, and it says that if it is for any a significant duration at all, it can go for a paraphilic disorder. Then 3, it must be causing distress to the individual and affecting the individual's functioning. Then 4, it must not be as a result of any other mental or behavioral condition or physical condition. Then what are the various types, the various paraphilic disorders? I would want to state this. Number 1 is pedophilia. Pedophilia, you have the general definition of the paraphilic disorder. In addition to that, you are interested in having sex or fantasizing about this is the key word, a prepubescent child. Prepubescent child. A prepubescent child is one that has not attained the various secondary sexual characteristics like breasts, like pubic hair, like that feminine body. Or if the difference between the two people is more than 5 years and the person is less than 16 years, it can be classified as a pedophilic disorder. We also have other paraphilic disorders like sadomasochism. In sadomasochism, it's a combined form. We have sadism and masochism. In sadism, the person inflicts pain on the partner. By inflicting pain on the partner, the person gets sexually aroused. In masochism, the person enjoys enjoys the pain that is being inflicted on the person. And take note, they may not even be having natural sexual intercourse, but the mere fact that the person is inflicting pain on you, you become sexually aroused. Then we have others like voyeurism, those who watch. We have frotteurism, those who touch on non-consenting individuals. You are in the club, you are in the market, and you touch somebody and you get sexually aroused, and you may even ejaculate. You understand? Then we have coprophilia, then we have necrophilia in feces, and then animals, zoophilia, and all of these other things. So these are the various paraphilic disorders that we have according to DSM and ICD 11.
Yeah, thank you very much. Yes, some people don't know, but there are people who have these paraphilic disorders, the coprophilia, the necrophilia. There are people who have it, frotteurism, voyeurism. There are people who have it.
Yeah,
and
do not.
I wanted. Yes.
Yeah, and then transvestic disorder. So yes. cross dressing. You cross dress, and you get sexually aroused for it. Yeah.
Good. People need to know that. So you see someone who is cross dressing, and you think the person, no, there could be a problem, and it has to meet the criteria for the diagnosis. And yes, so it's real. There are people, not to spoil anybody's appetite, but there are people who are aroused with excreta.
Yeah.
Dr. Azu said it. Excreta, human excreta. I just tried to, galvanize it a little.
Yeah.
And there are people like that, and it's real. So thank you very much, Dr. Azu, for such an elaborate presentation. At this point, we have a few minutes. Please drop your questions in the comment section, in the chat box, as many of them as you can. And Dr. Azu, as we always know him, he will gladly answer all the questions. Please drop all your questions in the comment section, in the chat box, on YouTube, on Zoom. Feel free, have your questions, and he will gladly answer all for us. He made us understand that women too can have blue balls, which is called pelvic congestion syndrome. So yes, it is real, and he said it's quite common, where a woman from desire, arousal, excitement stage, but she's never able to reach the climax, and that leads to a lot of complications. And he told us about how to manage that, which means, just as a side, their partners have work to do. That is why he's teaching us, sharing with us. He also made a statement that size does not matter, but skill is what matters most. Size does not matter, but skill is what matters most. All right, so any questions, please drop it in the chat box. Dr. Azu will gladly answer all the questions for us. Any questions at all, please drop it in the chat box. Dr. Azu will answer all for us. Dr. Azu, a lot of people talk about premature ejaculation. And first of all, before that, a lot of young people have the notion of, one, possibility of increasing the size of their manhood, and two, using herbs to prolong their sexual acts. What is your comment on this?
Thank you very much, Dr. Sedohia. This is very important, and it saddens my heart when I see young men wanting to increase the size of their penis, or when I see young men going to take drugs in order to prolong their sexual encounter. They are rather doing more damage to themselves. In the immediate, in the interim, they may be enjoying it. But in the long term effects are so dire that without the substance, now you cannot get the erection anymore. And that is why I am particularly interested in this and going on a personal campaign to ensure that people understand what sex is and know the right technique for having sex. You can prolong your sexual encounter just by understanding the physiology of sex, just by understanding how to do it. The how is more important to me. And people who understand the how are able to delay their ejaculation. People who understand the how are not concerned about the size of their penis. You understand? Of what use is an AK-47 to a baby, to a toddler? It is of no use. But if you give that same AK-47 to a soldier or to a trained ISIS man, the person would cause havoc to the nation. And so your size or your AK-47 size does not matter, but it is what you do with your pistol that matters. And it's very important to me. And I would advise that young men should stay away from drugs that are purported to increase the size of their penis, or from drugs that prolong sexual erection.
All right, thank you very much. If anybody has any questions, please feel free and drop it in a chat box. Feel free and drop it in the chat box. I just want clarification. Let people know, is it possible to increase your manhood with medications?
Yes. So, yes, it is possible. And then I would also want to state this. There are also certain techniques that can actually elongate your manhood and increase the size of your manhood. You understand what I'm saying? So yes, it is very possible. So a person's penis has has muscles. These muscles include smooth muscles and also skeletal muscles in between the skeletal muscles and the smooth muscles. And so frequent use of these ones can cause you to have an apparent enlarged penis. You understand what I'm trying to say? Frequent use of it can cause you to, as compared to infrequent use or a lack of use at all, can also cause a person to have a perceived decreased size of penis. Then again, I would want to add this, that a third of the penis cannot be seen by the eye. A third of the penis cannot be seen by the eye. And so you would notice that apparently people who are usually obese, they will say that this person is fat. And fat people have what? Small penises. It is because of the presence of the pelvic and abdominal fat that hides the penis. But if these people lose weight, you understand, if they lose weight, you would notice that the penis would increase in size. So somebody comes to me, the person seems to be obese, the person has, and you know, when you are obese, your fat can be distributed in various areas. In this particular person, the fat is mostly in the pelvic area. All the person needs to do is pelvic exercises, is to engage in exercises that will burn the fat around that particular area. And then boom, like magic, the penis size would increase. And so, yes, there are ways in which that you can do to increase the size of the penis. And there are also medications that increase the size of the penis as well.
Just to rehash, what are the complications associated with the use of these common herbs? Because almost all the advertisement on all the radio stations, they have a lot of herbs, a lot of alcoholic beverages, mostly alcoholic based, right? That promotes longevity with their sexual encounter and all that, Doc. So the herbs plus the alcoholic base, what is your comment on that?
Yes. So you see, all of these herbs, drugs, and all of these things, they have systemic changes that they occur in your body. You understand? And most of the time, you would notice that they are causing more damage to your body than your eye is even seeing it. Some of them have nitric oxide, and the nitric oxide would go into various parts of your body, causing dilatation of your vessels in those particular areas, and can cause you to have a stroke. They can cause you to bleed in areas that you should not be bleeding. Because if you have excessive nitric oxide in your body, it can cause heartburns, it can cause muscle aches, and it can also cause bleeding in parts of your body that you will not know. And these ones are usually very long term. But because it is accumulated over a period of time, you would not know that your stroke that you are getting at 40 years was as a result of the medications that you were taking when you were 20 and when you were 30. Then again, one becomes dependent on these drugs to the extent that now without the drugs, you cannot even get an erection. And the time will then reach that even with the drugs and the herbs, you may not even be able to maintain or even acquire an erection. So these are some of the side effects that these penis enlargement drugs or products can cause to you.
All right, thank you very much. So there's a question in the chat box. There's a question in the chat box. Somebody said, what do you mean by frequent usage of the penis? Is masturbation part of the frequent usage that you were talking about?
Yeah, very good question. So when I talk about frequent usage, I am talking about frequent sex. In the context of somebody who keeps having sex, the person is likely to maintain the size of the penis or increase the size of the penis as compared to somebody who does not even have sex at all. But nature is such that the erections we get at midnight during REM sleep would usually would usually cover for that. So one would say that, so Reverend Fathers who do not have sex doesn't mean that their penises are small. They do get erections, and they get erections usually at night in REM sleep. And so that would cover for it. But for masturbation, this is the downside of masturbation. Masturbation can be very addictive. Some form of masturbation or masturbation in certain contexts can be beneficial in the sexual response process. But if you have masturbation frequently, especially if you have masturbation daily, I have seen patients who come to me and they masturbate at least 3 times in a day. This masturbation can cause scarring of the penis because the penis is being used at a place that it should not be. And the epithelium of the hand is thicker and rougher than the vaginal walls. And so it does not matter the cream that you use, it can still cause the scarring. Then again, the penis is conditioned to get stimulated by the hands, such that if the vagina is supposed to stimulate it, you would have a premature ejaculation. And so masturbation on itself for a longer period of time can cause somebody to have premature ejaculation. Masturbation once or twice, at least a month, prior to having sex can cause a delay in ejaculation. I don't know if what I'm saying is making sense. It's a bit confusing, but then once you get a chance, and depending on what your problem is, we explain some of these things to you, it is usually very helpful. And so masturbation can be good and masturbation can be bad.
All right, thank you very much, Dr. Azu. Thank you. Somebody is asking, she didn't join early, so I will advise when the recording is shared, you'll go and listen to the recording so that you can get the full context of what he shared with us. Share the YouTube link so you can subscribe and benefit from the recording. But she's asking, what is the actual time to reach climax for a lady?
Yeah, there is no time. There is no time. A lady can reach climax in less than 1 minute, and a lady can reach climax in 30 minutes.
Good. She's also asking, what makes sex abnormal in a woman? Is it when she asks for more frequently or when there's pain during penetration?
Both of them are abnormal. Good. Even if you do not ask, it's abnormal, because it can be hyperactive sexual disorder, it can be sexual aversion disorder, and it can be a lack of sexual enjoyment.
Yes.
Yeah.
Okay. All right. Any more questions? Any more questions? Please feel free. Feel free to. We have few minutes more. Dr. Azu is still here with us. Feel free to ask your questions in the chat box comment section, and he will answer us. All right. Thank you very much, Dr. Azu. That was very elaborate and very extensive. We appreciate you. A lot of people I've had most of my questions answered. That's why I don't have a lot of questions to ask. I'm sure it's the same with most of the participants as well. If anybody has any questions, please put in the chat box or the comment section, and Dr. Azu will gladly help us with the response. Okay, in the absence of any question, Dr. Azu, please, what are your final words when it comes to sexual disorders?
So my final words are this. No man is born having knowledge and an understanding of good mathematics. It is learned. But please, this is the caveat. It does not mean that if you learn it before sex, before marriage, you would be good or better at it when you marry. No. I am a promoter and an advocate of learning sexual intercourse right and from the right people. So please, let us go home with this particular message that the act, ACT, of sex is an art, it's an ART that must be learned by all of us, including we medical professionals. Thank you very much.
The act is an act. Sex, the act of sex is an act that must be learned by everybody. Thank you very much, Dr. Azu. For those of you who may not be privy to what he has helped us with, there's a recording on the channel where he took us through orgasm, how to go about it, what to expect, everything you need to know about orgasm. The very topic that most people don't talk about openly. A few weeks ago, he took us through details of it, what is expected, how to go about it, how to help your partner reach orgasm, because everybody is entitled to reaching orgasm. So if you are not privy to that, it's on the channel. The recording is on the channel. If you joined us late, please feel free. The recording will be dropped and then you can benefit from it as well. Thank you very much for making time joining us for this presentation. We talked about sexual disorders, and there are lots of them. And then we also talk about paraphilias, and there are lots of them as well. If you listen well, you will learn a lot, and so that you can also teach other people. We will encourage that you share the recording, you share and let your friends subscribe to the channel and share the recording so that as many people as possible can benefit from the knowledge from the expert and authoritative good content that you have free of charge. Thank you very much for making time, Dr. Azu. Once again, thank you. And to all of you, our audience, live audience, and those who are going to be watching and listening to the recording, we appreciate you. We keep growing on YouTube, and we appreciate you all. Thank you, thank you, thank you, thank you, thank you. Once again, it's been a pleasing pleasure serving you all. Enjoy your morning, afternoon, evening, based on where you're reaching us from. Until I come your way again, it's me, your friend, Dr. Albert Sedun.